Welcome back, everyone. We're going to continue our advanced pharmacology series by talking about neurologic and GI medications. As a reminder, medications discussed in this lecture are intended for a brief overview of the common medications in the noted area and are for education purposes only. Please remember that allowed medications, their specific doses, indications, and uses will be subject to individual states, EMS services, and medical control physicians. Always follow your local and state policies, regulations, guidelines, and protocols for specific medications in your service area. When we talk about neurologic medications, we've broken this class out to speak about medications that have an impact on the CNS or central neurological system. First and foremost would be the class of opioid medications or narcotic medications. These are used as analgesics in the pre-hospital setting. They stimulate the opioid receptors to relieve pain, and they're known to cause tolerance, cross-tolerance, and addiction. They can cause profound sedation, respiratory depression, and apnea when excessive doses are administered, or when routine doses are administered in combinations with the patient's use of opioid-similar medications. With opioid medications, we have two primary medications that we see commonly in EMS. The first is morphine sulfate. This is known to cause nausea and vomiting in up to 60% of patients, and it may produce a histamine release. Morphine is often given in combination with antiemetic or anti-nausea medications such as Zofran or Phenergan to help combat this common side effect. Fentanyl, or Sublimase, does have the same risk of nausea and histamine release, but seems to be experienced less frequently by patients in the pre-hospital setting. Fentanyl can also be administered intranasally. Morphine sulfate is a naturally occurring medication, while fentanyl is a synthetic version of the opioid. We also have opioid antagonist medications. Naloxone, or Narcan, reverses the effects of excessive opioid chemicals in the body. The efficacy of this medication is dose-dependent and only administer enough to correct life-threatening conditions associated with excessive opioid toxicity. And this is predominantly respiratory depression or apnea, and we should only titrate the administration to bring back spontaneous respirations. And in a side note, if you're delivering opiates to a patient for pain management and you overdose that patient, once you provide them with the opiate antagonist, such as naloxone, you're no longer going to be able to administer pain medications effectively to this patient, as they'll have no effect on the patient's body. The other thing of note with naloxone is that oftentimes naloxone won't last as long as the effects of the opioid itself, so you may have to redose the patient frequently during transport. Other opiate antagonist medications are medications like Dilantin or phenytoin and fosphenytoin or Cerebrix. These are designed to prevent seizure activity and may be received on a long-term basis. Typically, they're administered by IV infusion, and they have fewer adverse effects from fosphenytoin than phenytoin. In sedative and hypnotic agents, one of the common medications that we use is etomidate or amidate. It's a derivative that works as a single-dose profound sedative, and it's typically used as pre-sedation for RSI or DFI procedures. It has a minimal effect on blood pressure. It begins working in 30 to 60 seconds, and it lasts approximately 5 minutes, with a maximum one dose only for patients. Another common sedative or hypnotic agent that we give pre-hospital is ketamine. This causes profound disassociation and anesthesia. The benefit is it can maintain blood pressure and heart rate, which is not the case with opiate medications. It does have the possibility to raise intracranial pressure, so caution should be used in patients with suspected increase in ICP. It does cause some degree of bronchodilation and is proven effective in treatments as a treatment adjunct for respiratory patients, particularly of pediatric respiratory patients needing airway management. Benzodiazepines are potent anti-seizure or anti-anxiolytic and sedative properties. They do require high doses for adequate sedation, but they can be used to treat active seizures. One thing to note is that benzos are a pregnancy class D and can be potentially harmful to the fetus. As we mentioned in some of the other medication lectures, you'll have to balance risk and benefit for these, and if you have a gravid patient that is having a seizure that is unbreakable, I would encourage you to consult medical control to try and get advice on administering this medication prior to doing so. We do have some medications that also affect the gastrointestinal system. Histamine 2 receptor agonists decrease acid secretion within the stomach, and they prevent histamine from stimulating receptor sites in the parietal cells of the stomach. These include medications like Zantac, Tagamet, and Pepcid. We also have antiemetic medications. These are used to treat nausea and vomiting. Common medications that you may see on the truck are promethazine or Phenergan and Compazine. They can be given orally or IV, and the adverse effects are really only related to the IV administration. Another common medication on the antiemetic class that you may see is Zofran or ondansetron. Reglan increases GI motility, and it's available orally or by slow IV injection or IV infusion. And then you also have 5-HT3 receptor agonists that can prevent certain mechanisms that induce vomiting. They're available in oral and IV preparations.